Bismillahirrahmanirrahim. This will be our fifth cardiovascular pathology lecture. It will be about another disease that affects arteries, arteriolosclerosis, specifically the hypertensive vascular disease. Blood pressure measurement is done using either a sphygmomanometer or a digital blood pressure monitor. Either ways will show us two types of blood pressure measurement. These are the systolic and the diastolic blood pressure measurements. Currently, a blood pressure is said to be high whenever a diastolic pressure is higher than 80 millimeter mercury or the systolic pressure is over 130 millimeter mercury. There are many ways to classify hypertension. One way depends on the severity of the condition, and using this method leads to the presence of two types of hypertension: benign hypertension and malignant hypertension. Another way to look at hypertension is according to the etiology or the underlying cause. And by this way, we can divide hypertension into primary or essential hypertension and secondary hypertension. Another way to look at hypertension is to decide the side of the circulation that is affected by the high blood pressure reading, meaning we have either systolic or a diastolic hypertension. About 5% of all hypertensive patients will experience attacks of rapidly rising blood pressure readings that can reach more than 200 millimeters mercury for the systolic pressures and more than 120 millimeter mercury for the diastolic pressures. This condition is called malignant hypertension. It is also known as accelerated hypertension. This condition is not related to a malignant process, but it's called so because of its dismal prognosis. It can lead to very important and very aggressive complications and mortality in those patients within 1 to 2 years if untreated. This condition can lead to end organ damage, consequently renal failure and retinal hemorrhages, plus other end organ damage. This condition is usually superimposed on a pre-existing benign hypertension of either etiology, so it could be an essential hypertension or a secondary hypertension. In many of the cases, this might be related to uncontrolled primary disease or secondary disease. So uncontrolled hypertension of any underlying etiology can lead to the following complications, or what we call target organ damage. It can lead to stroke and multi-infarct dementia. It can lead to atherosclerotic coronary heart disease and progression of this atherosclerosis. It can lead to cardiac hypertrophy and consequently heart failure, or what we call the hypertensive heart disease. It might also affect the aorta, leading to aortic dissection. This condition will be discussed later. It can lead to renal failure and retinal hemorrhages. Once again, hypertension can be classified according to etiology into essential or idiopathic hypertension and secondary hypertension. Most of the cases belong to the essential hypertension, 95% of all. Secondary hypertension most commonly is related to renal disease or renovascular disease. That's why it's called renovascular hypertension. Other less common things that might lead to secondary hypertension include many other conditions. So as you can see here, the list is very long. It contains many things like renal conditions, endocrine conditions, cardiovascular disorders, and even neurological disorders. Pathogenesis of essential hypertension include many things like genetic factors and some environmental influences. Genetic factors that are related to essential hypertension may be something related to familial clustering of hypertension like gene polymorphism or susceptibility genes for essential hypertension. Environmental factors are said to modify the impact of genetic determinants. Those environmental factors include stress, obesity, smoking, physical inactivity, and high salt consumption. We have mentioned before that blood vessels affected in hypertension are mainly the arteries, specifically arterioles, the smallest sized arteries. We called this condition in the previous lecture arteriolosclerosis. So hypertension is associated with arteriolosclerosis, or what we call small arterial disease. There are two forms of small blood vessel diseases that are hypertension related. These are hyaline arteriolosclerosis and hyperplastic arteriolosclerosis. The first type, hyaline arteriolosclerosis, this condition is associated with benign hypertension. It was called hyaline because of the pinkish homogeneous material that is causing the thickening of the wall of the arteriole. This thickening of the arteriole will lead to eventual luminal narrowing, and it will have important determinants on the tissues that are supplied by those arterioles. The luminal narrowing and the pinkish material within the wall of these arterioles comes from leakage of plasma proteins that come across the injured endothelial cells. So hypertension here will lead to micro trauma to the endothelial cells, and this trauma to the endothelial cells will lead to injury of the endothelial cells and leakage of some plasma proteins into the wall of these arterioles. This will also lead to an inflammatory response in the wall, and smooth muscle cells that are lining the media of these arterioles will form extracellular matrix proteins, adding to the thickening of the wall, and this is also a response to the chronic hemodynamic stress that is caused by the hypertension. Hyaline arteriolosclerosis can affect any organ, but it's most profound in the kidney. In the kidney, this chronic damage that affects the arterioles will eventually lead to nephrosclerosis, or what we call glomerular scarring, and this will lead to chronic renal failure with time. There are certain other conditions that might lead to hyaline arteriolosclerosis without the presence of hypertension, and these are diabetes mellitus, as well as part of the aging process. So elderly people, even if they are normal tensile, they might develop progressive hyaline arteriolosclerosis. The other type of arteriolosclerosis is hyperplastic arteriolosclerosis. This type is associated with malignant hypertension, and the hallmark of this condition under microscope is called the onion skin appearance of the arterioles. And this onion skin appearance of the arterioles is the result of concentric laminated thickening of the wall, which leads to eventual luminal narrowing and even complete occlusion of injury or trauma that develops in those arterioles following the recurrent attacks of very high blood pressure readings. Another abnormality that can be seen with malignant hypertension is fibrinoid vessel wall necrosis, or what we call necrotizing arteriolysis.